And again, I'm presenting for colleagues, although in this case I'm actually part of the project, and hopefully can answer questions well. Data harmonization, it's been interesting to sit on the panel because it's clear that data harmonization is something that a lot of people are doing, often by another name. Another term for this is integrated data analysis, and in its simplest case, what people are doing is analyzing individual level raw data pooled from multiple studies. And you can think of this as a contrast with meta-analysis, where you have the analysis of study level data, usually summary measures like odds ratios or means and standard deviations pooled from multiple studies. Harmonization, much like meta-analysis, is usually done as a post hoc activity. Here we have the advantage of having done it as a planned research activity, and as a funder we have the leverage of requiring it as part of our funding announcements. But even under those circumstances, and perhaps because of the slightly coercive nature of making something a requirement, this is something that really requires collaboration among the PIs, anticipation of some of the issues that may come up, and a knowledge of techniques to combine adapted or differing measures of the same construct. And I won't be spending much time with that, but that is an important part of the step, that if you've tried to combine data where there's different methods for case ascertainment, different paper and pencil questionnaire measures of certain constructs, you've probably gone through this process. And there are a variety of techniques like item response theory that have been developed to try to enable people to use somewhat different measures or adapted versions of the same measure to look at the same construct. In practice, when people do this as a post hoc activity, it's often been described as incorporating aspects of community-based participatory research, that really people have to be interested in looking at the same outcomes and willing to share data, often with people they haven't worked with before. Why would you want to harmonize? Well, in this case, we're harmonizing across our seek, test, treat, and retain protocols. So there are typically common areas of research, although they vary somewhat within the cohorts of studies that we have. Harmonization, by bringing together individual level data, increases your power, increases the capacity to answer new questions. You have cross-study comparability so that you can look at whether there's cross-site replication. You also have the capacity to do meta-analysis because, of course, these various measures will also be things that you can aggregate as summary measures. And so you can also look at population and you can also look at population effects. I mentioned yesterday 2 cohorts of seek, test, and treat studies that we've done. One involves criminal justice, and so these are done in correctional settings, which might be community corrections where there's supervision of people by the criminal justice system. They might be in jails, they might be in prisons. All but one of these studies was done in the United States. And so this was our first attempt at doing this approach and beginning to bring together studies. And again, this probably needs no introduction for people, but the seek, test, treat, and retain approach, the ultimate goal is to reduce viral load, reduce community viral load, and ultimately reduce HIV transmission. But not all studies contain all aspects of the cascade. So particularly in the criminal justice cohort of studies, we have some that emphasize the seek and test. Most of the studies are really looking at test and treat. Some are really emphasizing the drug treatment aspect. Others, the HIV linkage to care aspect. So this is, now, one of the things that makes harmonization complicated is that you often have a heterogeneous set of studies in terms of method, in terms of outcome, but in this case we do want to be having effects on clinical outcomes. The second cohort of studies we had, which were funded a year later, seek, test, treat, and retain. So there was more emphasis on retain in this cohort of studies. And as you can see, it's a large, more international group of studies with a variety of different populations. For us, vulnerable populations are really the traditional high-risk populations, including high-risk heterosexuals. Okay, and you can see with these studies also heterogeneous, but some of the studies get to all of the elements of seek, test, treat, and retain. And a number of studies are emphasizing the treat and retain, which I think a number of people have highlighted across the workshop as being a particularly important area in terms of maintaining the clinical gains of this approach. In terms of the domains where we're trying to harmonize, you can see that they're a very heterogeneous group. They include demographics, mental health variables, for the criminal justice studies, the criminal justice status, where are they in the system, drug use, other kinds of HIV risk, HIV, HCV testing in our HIV negative initial populations, access to care, treatment utilization, adherence, and biological data, which typically are CD4 and viral load. Our initial estimates of the samples, as you can see, are quite large, with total N's of almost 30,000 people across the 12 criminal justice studies, over 40,000 people in the vulnerable population studies. And the vulnerable populations studies have more in the way of HIV positive people at baseline, which helps explain the differences in terms of viral load and CD4 that we see as potential samples. In terms of the expected N's for the harmonization domains, you can see here the criminal justice studies, not all of them are enrolling HIV positive people at baseline, so the numbers of viral load and CD4 are relatively small compared with other variables, which are typically in the neighborhood of 3,000 to 4,000 people. In terms of the harmonization measures, people submitted proposals. There was an effort to reconcile one over another. There were some practical considerations in terms of people wanting to use, for example, licensed mental health measures that involve costs, and so there were some decisions people had to make there. But as you can see, across the different harmonization domains, there is a large proportion of measures which are the harmonized measures, and then people have added some additional measures, for example, most often with mental health or service utilization. People also have done adaptations of measures, and most often these have occurred with the access to care variables. But as you can see, no, actually, most often they've occurred with the demographics and the drug and alcohol use. And I think one of the issues in drug and alcohol use with HIV studies is that there really hasn't been an adaptation or an adoption of a specific gold standard measure. And so there are brief measures, particularly for alcohol, and much more complex measures that are often dictated by the very complex kinds of drug use that exist in populations. I think one of the things that we rediscover is that opioid injectors often use stimulants, often use alcohol. Drug use tends to be something that's much more heterogeneous than even people working in the field think about. Okay, in terms of our vulnerable populations grants, again, much larger N, and the majority of these studies are recruiting people who are HIV positive at baseline. The experience in terms of harmonization is somewhat better than with the criminal justice grants. These were funded a year later, and despite the heterogeneous nature of the populations, we had the earlier experience to build on. Although there's still a lot of adaptation of measures. In this case, they have tended to be adherence measures where, because these are HIV positive samples to a large extent, people often have experience with one measure or another, and there aren't a set of gold standard measures. And here there's a lot of interest in health literacy, and again, this is an area that has not really generated its own gold standard. And you have the issue of mental health, which I mentioned previously. In terms of where we are with this initiative, we have funded a data coordinating center at the University of Washington, which will be providing the technical assistance and coordinate the integration and also assist with the dissemination of findings. And we now have reached a point where we have baseline data across all of these studies and all of the initial follow-ups. And so in terms of future steps, we will be continuing to collect data and begin working toward formally integrating the data set. And what we're hoping to do is to expand the harmonization to incorporate other funded grants that we have that are in related areas. We have actually now a large number of such grants, and trying to incorporate surveillance data where that's possible, but also trying to incorporate data sets from other NIH or US government funded research projects, such as the HRSA, SAMHSA special projects of national significance, which tend to be much more about demonstration projects in the community, Ryan White programs, and the various other HIV research trial networks. In terms of the specific questions, I think most of these are fairly straightforward. The questions we want to answer across these studies, we want to look at aggregate impact on viral load. We want to see if we can find metrics in terms of the threshold length of retention that's necessary to demonstrate clinically significant reductions in viral load. We want to look at risk factors and risk behaviors at critical points, particularly in the criminal justice studies where there are clinically known important critical periods, particularly at release, but there may be other important periods in other populations. And also looking at potential for iatrogenetic or adverse effects. And also, by having these large data sets, getting a better sense of why and who we don't have in these clinical trials. Who are the people who are ineligible? Who are the people who consistently decline? Or who are the people we know are important who aren't reached in these studies? And so I'd like to thank actually the participating clinical trials and their principal investigators, and thank you for your time.